as we started to discuss the issues, the topics about blood banking or immunohematology and transfusion medicine. Now, lastly, we were talking about the adverse effect of the transfusion, right? Although the safety of transfused blood has improved, however, substantial risk of associated with the transfusion remain. And clinically, the result of the red blood cells destruction is known as transfusion reactions. The reason of the reactions, the transfusion reactions, is that the destruction of the red blood cells. Now, there are several symptoms or signs of the transfusion reactions. As I told you yesterday, these are chills, high temperature, pain in the lower back. This is because of the kidneys, because kidneys involved in such reactions firstly, and vomiting, shock, disease, which indicates the decrease of blood pressure and rapid pulse. Okay, the first effect of the transfusion reactions are rarely fatal, but the byproducts of the red blood cells destruction pose many problems, such as kidneys impairment, maybe is the most common side effect of the transfusion. Now, here we also already talk about that. The main adverse effect of the transfusions are immediate immunologic adverse reactions, such as TRALI, hemolytic transfusion reactions. That means destruction of the red blood cells. You see hemolysis in the blood. It can be acute hemolytic transfusion reactions, ABO incompatibility between the donor and recipient is the most common type of acute hemolytic reactions. It can be also delayed hemolytic transfusion reactions. Okay, the first one, as soon as you administer the blood of the donor to the patients, maybe it started in a few minutes, the symptoms, but the delayed hemolytic transfusion may be started a few days late after the blood transfusion. Now, we also have some immediate non-immunologic adverse reactions due to the transfusion. Now, for each topic to learn better, I usually recommended my students to understand the pathophysiology of the issues. Okay, if you understand the pathophysiology, you don't need to memorize most of the information, because it will come in your minds if you know the pathophysiology. Okay, now the pathophysiology of the hemolytic disease of the fetus and newborns is really interesting, and the mechanisms involve sensitization or immunization of the mother to the foreign antigens, this antigen can be either ABO or Rh antigens, which present on her child red blood cells. If any incompatible fetal red blood cells enter the mother circulation system, then she can be synthesized to the antigen and potentially develop an antibody to the antigen on the fetal red blood cells. Okay, how can how can a mother can be synthesized to the red blood cells? For that, the red blood cells should enter in mother circulation, right? Okay, how they can enter into the mother circulation? Normally, they are not able to pass through the placental tissues. However, during the delivery, if you damage the placental vessels, it might be some erythrocytes enter into the mother circulation. Okay, if immunization after entering of the child's red blood cells into the mother circulation, okay, if these antigens are not recognized, okay, or recognized as a foreign antigens, and then immunization occurs. Okay, the mother will develop antibody to the antigens, okay, which is a permanent. Now, once the mother develop antibodies, and these antibodies, if these antibodies are IgG type, immunoglobulin G type of the antibodies, we know that among the immunoglobulins, only IgG are able to pass through the placenta, come into the mother circulation because of their size. Okay, IgG, have a smaller size, and only IgG antibodies can cross the placenta into the circulation system, okay, of the mothers or of the fetus. Okay, okay. Once the antibodies form and cross the placenta into the circulation system of the fetus, okay, and they will react with the red blood cells of the child. Okay, now this is the pathophysiology of the hemolytic disease of the fetus and newborns. Okay, there are two reasons. Disease, I mean, it can be synthesized either to the ABO antigen or Rh antigens. Now, okay, here the ABO antigens, okay, which is most often hemolytic disease of the fetus and newborns, occurs as a result of antigen in the ABO systems. The mother is usually, in this case, the mother is usually group O, and the child inherits the A or B antigen from the father. Okay, if you remember from the previous lectures, from yesterday, I told you that in group O patients or a person, they don't carry antigens. right? They only have antibodies. Agree with me? If the child inherits A or B antigen from father, okay, and once these the erythrocytes of the child enter into the mother circulation, then the mother will react with this antigen and then produce antibodies. Now, the second antigens that will be dangerous, that will interact with mother's immune systems is Rh antigen. In the case of Rh incompatibility, the mother is Rh negative or you can say negative for D. You know, there are systems. In the Rh system, the D antigen is most important. And father is positive for D, mother is Rh negative, and father, if mother is Rh negative and father is Rh positive, and the child is Rh positive, okay? These are probability, okay? It doesn't mean that 100% the child will be Rh positive, okay? If the child is Rh positive and if any D positive or Rh positive red blood cells of the fetus cross into the mother circulation, she may develop an immune antibody, anti-D antibody, and these are IgG and immunoglobulins, IgG antibodies. These are able to cross the placenta and react with the red blood cells of the fetus. Okay, now this diagram shows the mechanism of action for hemolytic disease of the fetus and newborns. We need to know that in the first pregnancy, almost nothing is happened. Now, as you see, if mother is Rh negative and the baby is Rh positive, okay, and during delivery, some of red blood cells of the babies will enter into the mother circulation, okay, and as we see here, a few erythrocytes enter into the mother blood circulation, and the mother immune systems stimulated by this erythrocyte because it's carry an antigen which is foreign to the mothers. And then we know that once the immune system encounter a foreign antigens, the B cells will they will differentiate into the plasma cells and memory cells, and these memory cells will stay for a long time, as the name implies. They memorize the same cells, same antigens once they encounters later, okay, again. Now, what happens next, which is most important, most serious, after during the second pregnancies, okay, if the the second child also is Rh positive, and the erythrocytes cross the placenta, come into the mother blood circulation. This time, memory cells will respond to them immediately and produce a high amount of the antibodies, and these antibodies are IgG and able to cross the placenta and attack the baby's erythrocytes. And then now the hemolysis will start it. Okay, because they will, once they attack to the erythrocytes, the immunologic reactions initiate and result in this destruction of the erythrocytes. Okay, now, but we are fortunate we can prevent such immunologic reactions if we treat the mother with Rogam, okay, a kind of medicine that we are using. We administered the pregnancy woman, okay, which prevent B cells activation, because B cells which produce antibodies, okay, this medicine, Rogam, will prevent B cell activation and memory cells formation, okay? And now, okay, what happens if the destruction of erythrocytes, baby's erythrocytes occurs? Okay, the destructions means that the destruction of the hemoglobin, right? And this hemoglobin will increase in the blood, and you know, the hemoglobin will degrade to the bilirubin, right? And globin will degrade to the amino acids and transfer to the amino acid pools. However, the bilirubin, which is the end product of the hemoglobin, is insoluble and should be glucurinated in the liver to become a soluble and to be able to transport via blood circulation. And for that, we need a glucuronide transferase enzyme in the liver. However, the liver of the newborn does not produce enough enzyme, which is glucuronide transferase, which is necessary for converting bilirubin to an excretable form. Okay, soluble bilirubin become a soluble for excretion, which is done by glucuronide transferase. Okay, consequently, bilirubin, if bilirubin is not converted to the soluble form, okay, which is indirect bilirubin or insoluble bilirubin, accumulate, and if not removed, will be deposited in the lipid-rich tissues, such as the brain, which can cause kernicterus, life-threatening conditions for babies. We have to prevent the development of the kernicterus. Excessive bilirubin in the circulation also result in jaundice, right? If the level of the bilirubin increase in the blood, we call jaundice, right? And now, how we can prevent such a conditions, okay, how we can save the baby. There are a treatment for that, as I said before. Now, first we have to diagnose such conditions, okay, the hemolytic disease of the fetus and newborns, okay. There are routine laboratory, prenatal and postnatal testing before delivery and after delivery. First, the type the mother for ABO and RH, and find out what is the blood group of the mother and whether she is RH negative and positive, okay, and screen for antibodies, whether the mother already developed antibodies against the baby's red blood cells, okay? If antibody found, and then you have to recheck titer throughout the pregnancy, okay? If the titer is too low, okay, that might be from the previous pregnancy, and you have to follow the titer or the level of these antibodies during the pregnancy. And after birth, okay, you will be able to type the infant bloods, okay? During the pregnancy, you cannot do that, right? And after birth, you have to type the blood of the infants, okay? And then if you find any kind of incompatibility, then you have to treat the mother, right? Or the baby, and the babies if needed. No, okay. It depends of the severity of the hemolytic disease of the fetus and newborns. Either you choose phototherapy, which degrade the bilirubin in the baby's blood, okay, and then converted them into the water-soluble components, or if needed, you have to exchange the baby's blood, which we call transfusion. Okay, it depends on the level of the bilirubins. Okay, if the bilirubins is about 20 milligram per deciliter, you have a risk of kernicterus. You have to start it with phototherapy and follow whether it's decreased or not, the bilirubin levels. If decreased, it's no problem. Otherwise, you may need transfusion, exchange of the baby's blood. Okay, now prevention of RH immunization. Okay, you have to administer Rogam, as I told you. Here, okay, prevention of sensitization of RH or D antigen. Okay, you have to administer Rogam by the antenatal or postnatal period. Okay, let's say before delivery. Okay, between 36 weeks of the pregnancy, or and after delivery, you have to administer the Rogam medicine to prevent development of differentiation of the B cells to produce, which produce antibodies. Okay. Yeah. Okay, no, that should be enough for these lectures. Blood banking's lectures is really wide. There are a huge information, but I tried to summarize for you guys. If you choose to be hematologist or laboratory scientist, you have to learn more. Okay. Now let's go ahead and send your responses to these questions. Okay, let's see. Okay, the correct answer is D. And you know the RH blood systems have several antigens, but D antigen, okay, yeah, okay, D, which C, D, A, and K. The correct answer is B, okay? Now, the antigens, okay, agree with me?
Yeah, we hear you.
Okay. The D antigen is the most important antigen in terms of RH blood groups, okay? Okay, next one. If a patient is group A, what is the preferred blood group for transfusion? You may think about the packed red blood cells, okay, and then choose the correct blood group for transfusion if a patient is group A. It is really easier. If patient is group A, you have to choose the group A blood group, right? If you, if among the options you have group A, you don't need to do you don't need to think about the other groups, okay, right? But if you don't have A group, you may think about universal donor, right? Now okay, the correct answer is A. Okay, you can transfuse group A blood group to the group A. Okay, because if you have group A, okay, you don't need to use the other ones. Okay, cross-matching of donors' red blood cells with the patient's serum could demonstrate okay, you cross-matching the donor's red blood cells with patient's serum. In the patient's serum, what we have is antibodies, right? Serum include antibodies, red blood cells include antigens. Okay. What could demonstrate if you cross-matching the donor's red blood cells and patient serum? So let's see your answer. Okay, the A is the correct answer. Measure incompatibility between patients' and donor. Okay. Verification of correct RH type is a let's say grouping, like, and is to identify the blood groups is other task. Okay, not is cross matching. Okay. Okay, which of the following are generally characterized as a transfusion reaction? Hemolytic reactions, okay, and febrile reaction, allergic reactions, all of them, none of them. Okay, all of them is correct. Good, guys. Good job. Okay, this is last question for today. If you add anti-A and anti-B serums on the erythrocytes, you will see an agglutination as seen in the pictures below. What type of the blood is it? Now you have to identify the blood group of the patient. Okay, this is group A. As you see, antiserum. Okay, these are erythrocytes, right? Okay, you add antiserum, which include antibodies on the erythrocytes of the patients. Okay, what we have on the erythrocyte surface, antigen, right? If anti-A reacted with these erythrocytes, that means we have A antigen here, and this is group A, right? And there is no reaction with anti-B. Okay.
So the answer is A?
Yes, because we have reaction here, right? With anti-A, not anti-B. What does means we have if we have reaction here, these erythrocytes, they carry A antigen. Okay, if you have A antigen on your erythrocyte surface, your blood group is A. Okay, the correct answer is A.